a WikiVidi Documentaries production. Don't forget to like and subscribe. Enjoy. Pulmonary embolism. Pulmonary embolism is a blockage of an artery in the lungs by a substance that has moved from elsewhere in the body through the bloodstream. Symptoms of a P may include shortness of breath, chest pain particularly upon breathing in, and coughing up blood. Symptoms of a blood clot in the leg may also be present, such as a red, warm, swollen, and painful leg. Signs of a P include low blood oxygen levels, rapid breathing, rapid heart rate, and sometimes a mild fever. Severe cases can lead to passing out, abnormally low blood pressure, and sudden death. P usually results from a blood clot in the leg that travels to the lung. The risk of blood clots is increased by cancer, prolonged bed rest, smoking, stroke, certain genetic conditions, estrogen-based medication, pregnancy, obesity, and after some types of surgery. A small proportion of cases are due to the embolization of air, fat, or amniotic fluid. Diagnosis is based on signs and symptoms in combination with test results. If the risk is low, a blood test known as a D-dimer will rule out the condition. Otherwise, a CT, pulmonary angiography, lung ventilation/perfusion scan, or ultrasound of the legs may confirm the diagnosis. Together, deep vein thrombosis and P are known as venous thromboembolism. Efforts to prevent P include beginning to move as soon as possible after surgery, lower leg exercises during periods of sitting, and the use of blood thinners after some types of surgery. Treatment is typically with blood thinners such as heparin or warfarin. Often these are recommended for 6 months or longer. Severe cases may require thrombolysis using medications such as tissue plasminogen activator, or may require surgery such as a pulmonary thrombectomy. If blood thinners are not appropriate, a vena cava filter may be used. Pulmonary emboli affect about 430,000 people each year in Europe. In the United States, between 300,000 and 600,000 cases occur each year, which results in between 50,000 and 200,000 deaths. Rates are similar in males and females. They become more common as people get older. Signs and symptoms. Symptoms of pulmonary embolism are typically sudden in onset and may include one or many of the following: dyspnea, tachypnea, chest pain of a pleuritic nature, cough and hemoptysis. More severe cases can include signs such as cyanosis, collapse, and circulatory instability, because of decreased blood flow through the lungs and into the left side of the heart. About 15% of all cases of sudden death are attributable to P. On physical examination, the lungs are usually normal. Occasionally, a pleural friction rub may be audible over the affected area of the lung. A pleural effusion is sometimes present that is exudative, detectable by decreased percussion note, audible breath sounds, and vocal resonance. Strain on the right ventricle may be detected as a left barosternal heave, a loud pulmonary component of the second heart sound, and/or raised jugular venous pressure. A low-grade fever may be present, particularly if there is associated pulmonary hemorrhage or infarction. As smaller pulmonary emboli tend to lodge in more peripheral areas without collateral circulation, they are more likely to cause lung infarction and small effusions, but not hypoxia, dyspnea or hemodynamic instability such as tachycardia. Larger Ps, which tend to lodge centrally, typically cause dyspnea, hypoxia, low blood pressure, fast heart rate and fainting, but are often painless because there is no lung infarction due to collateral circulation. The classic presentation for P with pleuritic pain, dyspnea and tachycardia is likely caused by a large fragmented embolism causing both large and small Ps. Thus, small Ps are often missed because they cause pleuritic pain alone without any other findings, and large Ps often missed because they are painless and mimic other conditions, often causing ECG changes and small rises in troponin and BNP levels. Ps are sometimes described as massive, submassive, and non-massive depending on the clinical signs and symptoms, although the exact definitions of these are unclear. An accepted definition of massive P is one in which there is hemodynamic instability such as sustained low blood pressure, slowed heart rate, or pulselessness. Risk factors. About 90% of emboli are from proximal leg or deep vein thromboses or pelvic vein thromboses. DVTs are at risk for dislodging and migrating to the lung circulation. The conditions are generally regarded as a continuum termed venous thromboembolism. The development of thrombosis is classically due to a group of causes named Virchow's triad. Often, more than one risk factor is present. Underlying causes. After a first P, the search for secondary causes is usually brief. Only when a second P occurs, and especially when this happens while still under anticoagulant therapy, a further search for underlying conditions is undertaken. This will include testing for factor V Leiden mutation, antiphospholipid antibodies, protein C and S and antithrombin levels, and later prothrombin mutation, MTHFR mutation, factor VIII concentration and rarer inherited coagulation abnormalities. Diagnosis. In order to diagnose a pulmonary embolism, a review of clinical criteria to determine the need for testing is recommended. In those who have low risk, age less than 50, heart rate less than 100 beats per minute, oxygen level more than 94% on room air, and no leg swelling, coughing up of blood, surgery or trauma in the last 4 weeks, previous blood clots, or estrogen use. Further testing is not typically needed. If there are concerns, this is followed by testing to determine a likelihood of being able to confirm a diagnosis by imaging, followed by imaging if other tests have shown that there is a likelihood of a P diagnosis. The diagnosis of P is based primarily on validated clinical criteria combined with selective testing, because the typical clinical presentation cannot be definitively differentiated from other causes of chest pain and shortness of breath. The decision to perform medical imaging is based on clinical reasoning, that is, the medical history, symptoms and findings on physical examination, followed by an assessment of clinical probability. Probability testing. The most commonly used method to predict clinical probability, the Wells score, is a clinical prediction rule, whose use is complicated by multiple versions being available. In 1995, Philip Stephen Wells initially developed a prediction rule to predict the likelihood of P, based on clinical criteria. The prediction rule was revised in 1998. This prediction rule was further revised when simplified during a validation by Wells et al. In 2000. In the 2000 publication, Wells proposed 2 different scoring systems using cutoffs of 2 or 4, with the same prediction rule. In 2001, Wells published results using the more conservative cutoff of 2 to create 3 categories. An additional version, the modified extended version, using the more recent cutoff of 2, but including findings from Wells' initial studies, were proposed. Most recently, a further study reverted to Wells' earlier use of a cutoff of 4 points to create only 2 categories. There are additional prediction rules for P, such as the Geneva rule. More importantly, the use of any rule is associated with a reduction in recurrent thromboembolism. The Wells score. Traditional interpretation recommendations for a diagnostic algorithm were published by the PIAPT investigators. However, these recommendations do not reflect research using 64-slice MDCT. These investigators recommended pulmonary embolism rule-out criteria. The pulmonary embolism rule-out criteria helps assess people in whom pulmonary embolism is suspected, but unlikely. Unlike the Wells score and Geneva score, which are clinical prediction rules intended to risk stratify people with suspected P, the PERC rule is designed to rule out risk of P in people when the physician has already stratified them into a low-risk category. People in this low-risk category without any of these criteria may undergo no further diagnostic testing for P, hypoxia, SAO 250, hormone use, tachycardia. The rationale behind this decision is that further testing may cause more harm than the risk of P. The PERC rule has a sensitivity of 97.4% and specificity of 21.9% with a false negative rate of 1.0%. Blood tests. In people with a low or moderate suspicion of P, a normal D-dimer level is enough to exclude the possibility of thrombotic P, with a 3-month risk of thromboembolic events being 0.14%. D-dimer is highly sensitive, but not specific. In other words, a positive D-dimer is not synonymous with P, but a negative D-dimer is, with a good degree of certainty, an indication of absence of a P. The typical cutoff is 500 G/L, although this varies based on the assay. However, in those over the age of 50, changing the cutoff value to the person's age multiplied by 10G/L is recommended, as it decreases the number of falsely positive tests without missing any additional cases of P. When a P is being suspected, several blood tests are done in order to exclude important secondary causes of P. This includes a full blood count, clotting status, and some screening tests. If one of these is abnormal, further investigations might be warranted. Troponin levels are increased in between 60 and 47% with pulmonary embolism. Imaging. In typical people who are not known to be at high risk of P, imaging is helpful to confirm or exclude a diagnosis of P after simpler first-line tests are used. Medical societies recommend tests such as the D-dimer to first provide supporting evidence for the need for imaging, and imaging would be done if other tests confirmed a moderate or high probability of finding evidence to support a diagnosis of P. CT pulmonary angiography is the recommended first-line diagnostic imaging test in most people. Historically, the gold standard for diagnosis was pulmonary angiography, but this has fallen into disuse with the increased availability of non-invasive techniques. Ultrasound of the legs can confirm the presence of a P, but cannot rule it out. CT pulmonary angiography. CT pulmonary angiography is a pulmonary angiogram obtained using computed tomography with radiocontrast rather than right heart catheterization. Its advantages are clinical equivalence, its non-invasive nature, its greater availability to people, and the possibility of identifying other lung disorders from the differential diagnosis in case there is no pulmonary embolism. Assessing the accuracy of CT pulmonary angiography is hindered by the rapid changes in the number of rows of detectors available in multi-detector CT machines. According to a cohort study, single-slice spiral CT may help diagnose detection among people with suspected pulmonary embolism. In this study, the sensitivity was 69%. And specificity was 84%. In this study, which had a prevalence of detection was 32%, the positive predictive value of 67.0% and negative predictive value of 85.2%. However, this study's results may be biased due to possible incorporation bias, since the CT scan was the final diagnostic tool in people with pulmonary embolism. The authors noted that a negative single-slice CT scan is insufficient to rule out pulmonary embolism on its own. A separate study, with a mixture of 4-slice and 16-slice scanners, reported a sensitivity of 83% and a specificity of 96%, which means that it is a good test for ruling out a pulmonary embolism if it is not seen on imaging, and that it is very good at confirming a pulmonary embolism is present if it is seen. This study noted that additional testing is necessary when the clinical probability is inconsistent with the imaging results. CTPA is non-inferior to VQ scanning, and identifies more emboli compared to VQ scanning. Brought to you by WikiVidi Documentaries. Would you like